Question 1. A patient is experiencing symptomatic bradycardia with a heart rate of 30 bpm, hypotension, and altered mental status. After ensuring airway and breathing, what is the initial drug of choice according to AHA guidelines? A. Epinephrine. B. Atropine. C. Dopamine. D. Adenosine. Answer B. Atropine. This question focuses on the immediate pharmacological management of symptomatic bradycardia, where the patient exhibits signs of poor perfusion like hypotension and altered mental status. The keyword initial drug of choice for symptomatic bradycardia points directly to atropine, as it is a parasympatholytic drug that blocks the vagus nerve's action, increasing heart rate. For example, if a patient's heart rate drops critically low and they become dizzy and hypotensive, atropine is the first medication to consider before moving to transcutaneous pacing or other drugs. Always remember that atropine is the frontline medication for increasing heart rate in patients with symptomatic bradycardia. Question 2. A patient presents with a regular, narrow complex tachycardia at a rate of 180 bpm and is stable. What drug is indicated for this rhythm? A. Amiodarone. B. Epinephrine. C. Adenosine. D. Lidocaine. Answer C. Adenosine. This question tests your understanding of the treatment for stable, regular narrow complex tachycardia, which is often supraventricular tachycardia, SVT. The keywords stable and narrow complex tachycardia are crucial clues here. Adenosine is the drug of choice because it temporarily blocks AV nodal conduction, allowing for the termination of SVT or revealing underlying atrial activity. For instance, if a patient is conscious but feels their heart racing very fast in a regular pattern, adenosine would be administered rapidly to try and break the rhythm. Remember that adenosine is the specific treatment for stable SVT to either convert it or aid in diagnosis. Question 3. What is the recommended initial dose of intravenous, 4-amiodarone for a patient with pulseless ventricular tachycardia, private, or ventricular fibrillation, VF, refractory to defibrillation? A. 1 mg 4-push. B. 6 mg rapid 4-push. C. 300 mg 4-bolus. D. 150 mg 4-bolus. Answer C. 300 mg 4-bolus. This question assesses your knowledge of the correct dosage for amiodarone during cardiac arrest due to pulseless ventricular tachycardia or fibrillation, especially when initial defibrillation has not been successful. The term refractory to defibrillation indicates that the patient's heart rhythm is not responding to electrical shocks alone. The AHA guidelines recommend an initial bolus of 300 mg of amiodarone for these life-threatening arrhythmias. If a patient continues in VF after the first few shocks, this specific dose of amiodarone is given to try and stabilize the heart. It's important to remember the initial 300 mg 4-bolus of amiodarone as a key intervention for persistent VF/private in cardiac arrest. Question 4. Which of the following drugs is absolutely contraindicated in a patient presenting with cocaine-induced chest pain? A. Aspirin. B. Nitroglycerin. C. Beta blockers. D. Morphine. Answer C. Beta blockers. This question highlights a critical contraindication for a common cardiac medication in a specific clinical scenario. The keyword cocaine-induced chest pain is the vital clue. Beta blockers are generally contraindicated in cocaine-induced chest pain because they can cause unopposed alpha-adrenergic stimulation, leading to worsening coronary vasoconstriction and hypertension, which can be harmful. For example, if a patient with chest pain admits to recent cocaine use, administering a beta blocker could dangerously increase their blood pressure and further restrict blood flow to the heart. Always avoid beta blockers in patients with suspected cocaine-induced chest pain to prevent severe adverse effects. Question 5. What is the primary indication for administering magnesium sulfate in a cardiac arrest setting? A. Asystole. B. Pulseless electrical activity, PEA. C. Torsades de pointes. D. Atrial fibrillation with rapid ventricular response. Answer, C. Torsades de pointes. This question targets the specific use of magnesium sulfate in the context of cardiac arrest rhythms. The most important indication for magnesium sulfate in ACLS is the treatment of torsades de pointes, a specific type of polymorphic ventricular tachycardia characterized by a twisting appearance on the ECG. For instance, if a patient goes into cardiac arrest and their ECG shows the characteristic undulating pattern of torsades de pointes, magnesium sulfate is the primary drug given to stabilize the heart rhythm. Remembering that magnesium is the definitive treatment for torsades de pointes will help you apply it correctly in emergency situations. Question 6. What is the recommended total maximum dose of atropine that can be administered for symptomatic bradycardia? A. 1 mg. B. 2 mg. C. 3 mg. D. 0.5 mg. Answer, C. 3 mg. This question tests your knowledge of the maximum safe dosage for atropine when treating symptomatic bradycardia. It's important to understand the total dose to avoid potential adverse effects while effectively managing the patient's condition. The AHA guidelines specify a maximum total dose of 3 mg of atropine for symptomatic bradycardia. If a patient with a slow heart rate and symptoms has received multiple doses of atropine, you should stop administering it once this cumulative dose is reached and consider other interventions like pacing. Always keep the 3 mg maximum dose of atropine in mind to guide your treatment of symptomatic bradycardia. Question 7. A patient in cardiac arrest has a rhythm of asystole. Which drug is the primary medication indicated for this rhythm? A. Atropine. B. Epinephrine. C. Lidocaine. D. Adenosine. Answer, B. Epinephrine. This question focuses on the immediate pharmacological treatment for asystole, a non-shockable rhythm in cardiac arrest. The keyword asystole immediately points to epinephrine as the primary vasopressor indicated to increase myocardial and cerebral blood flow during CPR. For example, when CPR is ongoing and the monitor shows a flat line, epinephrine is administered every 3 to 5 minutes to try and restart electrical activity and improve the chances of return of spontaneous circulation. Remember that epinephrine is the cornerstone drug for all non-shockable rhythms, including asystole and pulseless electrical activity, PEA. Question 8. What is the primary mechanism of action of adenosine when used to treat supraventricular tachycardia, SVT? A. Blocks beta-adrenergic receptors. B. Increases myocardial contractility. C. Temporarily blocks conduction through the AV node. D. Dilates coronary arteries. Answer, C. Temporarily blocks conduction through the AV node. This question delves into the pharmacological action of adenosine, specifically its effect on the heart's electrical system in the context of SVT. The keyword mechanism of action asks how the drug works. Adenosine rapidly and temporarily blocks conduction through the atrioventricular, AV, node, which is essential for interrupting reentrant pathways that cause most SVTs. For instance, By causing a brief pause in the heart's electrical activity at the AV node, adenosine can effectively reset the rhythm to normal sinus rhythm. Understanding that adenosine works by pausing AV nodal conduction helps explain its rapid onset and short duration of action in treating SVT. Question 9. For a patient with stable wide complex tachycardia, which antiarrhythmic drug can be considered as an alternative to amiodarone if amiodarone is not effective or contraindicated? A. Adenosine. B. Diltiazem. C. Lidocaine. D. Digoxin. Answer: C. Lidocaine. This question explores alternative drug options for stable wide complex tachycardia, assuming the primary treatment, amiodarone, might not be suitable or effective. The crucial phrase "alternative to amiodarone" indicates that you need to know another antiarrhythmic with similar properties for ventricular arrhythmias. Lidocaine is a class IB antiarrhythmic that can be used for stable monomorphic ventricular tachycardia when amiodarone is not indicated or effective. For example, if a patient has a stable wide complex rhythm and amiodarone causes side effects, lidocaine could be considered to suppress the abnormal ventricular electrical activity. Always consider lidocaine as a viable alternative for stable wide complex tachycardia, especially when amiodarone is not an option. Question 10. A patient presents with acute coronary syndrome, ACS, with ongoing ischemic chest pain. What is the initial antiplatelet medication recommended? A. Clopidogrel. B. Aspirin. C. Heparin. D. Abciximab. Answer: B. Aspirin. This question focuses on the immediate pharmacological management of acute coronary syndrome, ACS. The keywords acute coronary syndrome and initial antiplatelet medication are crucial. Aspirin is the first-line antiplatelet agent recommended for ACS because it inhibits platelet aggregation, preventing the formation of new clots and reducing the size of existing ones in the coronary arteries. For instance, if someone is having a heart attack, giving them aspirin as quickly as possible helps to thin their blood and improve blood flow to the heart muscle. Remember that chewable aspirin is a critical initial intervention for anyone suspected of having a heart attack. Question 11. What is the recommended dose of intravenous, for epinephrine for cardiac arrest? A. 0.1 mg every 3 to 5 minutes. B. 0.5 mg every 3 to 5 minutes. C. 1 mg every 3 to 5 minutes. D. 3 mg every 3 to 5 minutes. Answer: C. 1 mg every 3 to 5 minutes. This question directly tests your knowledge of the standard dosage for epinephrine during cardiac arrest. It's essential to know the precise dose to ensure effective resuscitation efforts. The AHA Guidelines recommend administering 1 mg of epinephrine intravenously or intraosseously, IO, every 3 to 5 minutes during cardiac arrest. For example, after initiating CPR and defibrillation, if indicate D, a 1 mg dose of epinephrine is given to try and improve the chances of the heart restarting. Always remember that 1 mg of epinephrine every 3 to 5 minutes is the standard for cardiac arrest. Question 12. A patient in cardiac arrest has persistent ventricular fibrillation, VF, after initial defibrillation and a dose of amiodarone. What is the next most appropriate antiarrhythmic drug to consider if amiodarone is ineffective? A. Atropine. B. Adenosine. C. Lidocaine. D. Diltiazem. Answer: C. Lidocaine. This question assesses your understanding of the sequential drug therapy for refractory ventricular fibrillation in cardiac arrest. The keywords persistent ventricular fibrillation and after initial defibrillation and a dose of amiodarone indicate that the first-line antiarrhythmic has been used and was ineffective. In such cases, lidocaine is the recommended alternative antiarrhythmic drug to consider. For instance, if a patient remains in VF despite shocks and an amiodarone dose, a dose of lidocaine would be administered to try and suppress the ventricular arrhythmia. Remember that lidocaine serves as a second-line antiarrhythmic option for refractory VF/private when amiodarone fails. Question 13. Which drug is primarily used to relieve chest pain associated with acute coronary syndrome, ACS, by causing vasodilation, especially in the coronary arteries? A. Morphine. B. Furosemide. C. Nitroglycerin. D. Dopamine. Answer: C. Nitroglycerin. This question focuses on a key medication used for chest pain in acute coronary syndrome and its primary mechanism of action. The clues relieve chest pain and vasodilation, especially in the coronary arteries, point directly to nitroglycerin. Nitroglycerin works by dilating blood vessels, which reduces the heart's workload, preload and afterload E, and improves blood flow to the heart muscle, thereby alleviating ischemic pain. For example, if a patient is experiencing crushing chest pain from a suspected heart attack, nitroglycerin is given to help open up their blood vessels and ease the discomfort. Always remember that nitroglycerin is your primary choice for vasodilation to relieve ischemic chest pain in ACS. Question 14. What is the main indication for administering sodium bicarbonate in ACLS? A. Routine use in cardiac arrest. B. Symptomatic bradycardia. C. Suspected hyperkalemia or tricyclic antidepressant overdose. D. Supraventricular tachycardia, SVT. Answer: C. Suspected hyperkalemia or tricyclic antidepressant overdose. This question tests your knowledge of the specific, rather than routine, indications for sodium bicarbonate in emergency cardiac care. The keywords main indication and understanding that it's not a routine drug are crucial. Sodium bicarbonate is not routinely recommended for cardiac arrest but is indicated in specific situations such as severe metabolic acidosis, hyperkalemia, high potassium levels, or tricyclic antidepressant overdose. For example, if lab tests show dangerously high potassium levels that are affecting heart rhythm, sodium bicarbonate can be given to help shift potassium back into cells and stabilize the heart. Remember that sodium bicarbonate is reserved for very specific conditions, not general cardiac arrest. Question 15. What is the recommended initial 4-dose of adenosine for stable narrow complex tachycardia? A. 0.5 mg. B. 3 mg. C. 6 mg. D. 12 mg. Answer: C. 6 mg. This question specifically asks about the initial dose of adenosine for stable narrow complex tachycardia. Knowing the correct dose is vital for effective and safe administration. The AHA guidelines recommend an initial dose of 6 mg of adenosine given as a rapid 4-push. For instance, if a patient's ECG shows a fast, regular narrow complex rhythm and they are stable, the first attempt to convert the rhythm would typically involve this 6 mg dose. Always remember the 6 mg initial dose of adenosine as your first step in treating stable SVT. Question 16. What is the primary reason for administering oxygen to a patient experiencing an acute cardiac event? A. To stimulate the heart. B. To reduce anxiety. C. To improve myocardial oxygen supply and reduce ischemia. D. To increase blood pressure. Answer: C. To improve myocardial oxygen supply and reduce ischemia. This question focuses on the fundamental physiological reason for oxygen administration during an acute cardiac event. The keyword primary reason guides you to the core benefit. Oxygen is given to increase the amount of oxygen available to the heart muscle, which is often experiencing a lack of blood flow and oxygen, ischemia, during an event like a heart attack. For example, by providing supplemental oxygen, we aim to reduce the strain on the heart and minimize damage to the heart muscle. Always remember that the goal of oxygen in cardiac events is to supply more oxygen to the struggling heart. Question 17. A patient with symptomatic bradycardia unresponsive to atropine now requires a continuous infusion to maintain heart rate and blood pressure. Which drug is an appropriate vasopressor for this situation? A. Norepinephrine. B. Dopamine. C. Phenylephrine. D. Vasopressin. Answer B. Dopamine. This question addresses the management of symptomatic bradycardia when initial atropine treatment has failed and a continuous infusion is needed. The keywords unresponsive to atropine and continuous infusion for heart rate and blood pressure stabilization are key. Dopamine is an appropriate alternative to atropine and can be used as a continuous infusion to increase heart rate and improve blood pressure in symptomatic bradycardia, acting as both a chronotrope and an inotrope. For instance, if atropine hasn't worked for a severely bradycardic patient, a dopamine drip can help maintain their heart rate and prevent hypotension. Remember that dopamine is a good option for persistent symptomatic bradycardia requiring ongoing support when atropine isn't enough. Question 18. What is the most significant adverse effect of administering an excessive dose of amiodarone? A. Hypertension. B. Tachycardia. C. Hypotension. D. Hyperglycemia. Answer C. Hypotension. This question tests your awareness of a common and significant side effect of amiodarone, especially when administered as a rapid or large dose. The keyword adverse effect associated with amiodarone points to its cardiovascular impact. Amiodarone is a potent vasodilator and can cause significant hypotension, particularly with rapid infusion, due to its peripheral alpha-blocking effects. For example, if amiodarone is pushed too quickly, a patient's blood pressure can drop dramatically, potentially causing further complications. Always monitor blood pressure closely when administering amiodarone, as hypotension is a common and serious side effect. Question 19. Which medication is used in the treatment of acute pulmonary edema, especially when accompanied by hypertension, by reducing both preload and afterload? A. Atropine. B. Nitroglycerin. C. Epinephrine. D. Dopamine. Answer B. Nitroglycerin. This question highlights the role of a specific drug in managing acute pulmonary edema, particularly with high blood pressure. The clues acute pulmonary edema, hypertension, and reducing both preload and afterload are definitive for nitroglycerin. Nitroglycerin's vasodilatory effects decrease the amount of blood returning to the heart, preload, and the resistance the heart pumps against, afterload, thereby improving the heart's efficiency and reducing fluid buildup in the lungs. For instance, if a patient is struggling to breathe with fluid in their lungs and high blood pressure, nitroglycerin can help relieve the congestion by easing the heart's workload. Remember that nitroglycerin is excellent for acute pulmonary edema with hypertension due to its broad vasodilatory effects. Question 20. A patient in cardiac arrest has a rhythm that shows organized electrical activity on the monitor but no palpable pulse. What is this rhythm called, and which drug is indicated? A. Asystole, atropine. B. Pulseless electrical activity, PEA, epinephrine. C. Ventricular fibrillation, VF, amiodarone. D. Bradycardia, atropine. Answer, B. Pulseless electrical activity, PEA, epinephrine. This question describes a critical cardiac arrest rhythm and its primary drug treatment. The description organized electrical activity on the monitor but no palpable pulse is the classic definition of pulseless electrical activity, PEA. For PEA, just like asystole, epinephrine is the primary vasopressor administered to stimulate the heart and improve coronary and cerebral perfusion during CPR. For example, if the monitor shows a normal-looking rhythm but the patient is unresponsive and has no pulse, you would continue CPR and administer epinephrine every 3 to 5 minutes. Always recognize PEA as a non-shockable rhythm requiring continuous CPR and epinephrine. Question 21. What is the recommended drug and dose for the treatment of suspected hyperkalemia that is causing significant ECG changes, such as wide QRS complexes? A. Sodium bicarbonate 1 milliequivalent/kg4. B. Atropine 1 mg/4. C. Magnesium sulfate 2g4. D. Calcium chloride 0, 5-1 gram/4. Answer, D. Calcium chloride 0, 5-1 gram/4. This question specifically targets the management of hyperkalemia causing cardiac instability. The key clues, suspected hyperkalemia and significant ECG changes, such as wide QRS, indicate an immediate need to stabilize the cardiac membrane. Calcium chloride, or calcium gluconate, helps to stabilize the myocardial cell membranes, preventing further depolarization and arrhythmia, without actually lowering potassium levels. For instance, if a patient has critically high potassium and their ECG shows life-threatening changes, administering calcium chloride immediately helps protect their heart from further damage. Always remember that calcium is critical for cardiac membrane stabilization in severe hyperkalemia. Question 22. A patient with chest pain and suspected acute coronary syndrome has received 3 doses of sublingual nitroglycerin without relief. What opioid analgesic is commonly administered next if pain persists? A. Fentanyl. B. Hydromorphone. C. Morphine sulfate. D. Meperidine. Answer, C. Morphine sulfate. This question addresses the stepwise approach to pain management in acute coronary syndrome when initial treatments are insufficient. The keywords suspected acute coronary syndrome, 3 doses of sublingual nitroglycerin without relief, and opioid analgesic point to morphine. Morphine sulfate is commonly used for persistent ischemic chest pain unresponsive to nitroglycerin, as it provides analgesia and also has vasodilatory effects, which can reduce cardiac preload and oxygen demand. For example, if a patient is still in severe pain after nitroglycerin, a dose of morphine can help alleviate their discomfort and further reduce the heart's workload. Remember that morphine is indicated for ongoing chest pain in ACS that doesn't respond to nitroglycerin. Question 23. What is the initial recommended dose of intravenous, 4, diltiazem for rapid ventricular rate control in atrial fibrillation or atrial flutter with a rapid ventricular response in a stable patient? A. 0, 25 mg/kg for 2 minutes. B. 0, 75 mg/kg for 2 minutes. C. 15 mg for 2 minutes. D. 300 mg for 30 minutes. Answer. A. 0, 25 mg/kg for 2 minutes. This question asks about the initial dosing of diltiazem, a calcium channel blocker, for rate control in a specific cardiac rhythm. The keywords rapid ventricular rate control, atrial fibrillation or atrial flutter, and stable patient are crucial. Diltiazem is used to slow the heart rate by blocking calcium channels in the AV node, thereby decreasing conduction. The initial recommended dose is 0.25 mg/kg for over 2 minutes. For instance, if a patient has a very fast, irregular heart rhythm but is otherwise stable, this dose of diltiazem can help bring their heart rate down to a safer range. Remember that 0.25 mg/kg is the starting dose for diltiazem when managing rapid AFib/flutter in a stable patient. Question 24. A patient in cardiac arrest has ventricular fibrillation, VF, that is refractory to defibrillation. What is the purpose of administering epinephrine in this scenario? A. To convert VF to normal sinus rhythm. B. To increase myocardial and cerebral blood flow. C. To slow the heart rate. D. To stabilize the cardiac membrane. Answer, B. To increase myocardial and cerebral blood flow. This question focuses on the primary physiological effect of epinephrine during cardiac arrest, even when ventricular fibrillation is present. The keyword purpose of administering epinephrine directs you to its core action. Epinephrine is a potent vasoconstrictor and cardiac stimulant, and its administration during CPR aims to increase coronary perfusion pressure and cerebral blood flow, improving the chances of achieving return of spontaneous circulation. For example, by tightening blood vessels and increasing the force of heart contractions, even if disorganized, epinephrine helps ensure vital organs receive some blood flow during resuscitation efforts. Remember that epinephrine's main role in cardiac arrest is to optimize blood flow to the heart and brain during CPR. Question 25. Which of the following is a potential side effect of rapid administration of adenosine? A. Hypertension. B. Persistent tachycardia. C. Brief asystole or bradycardia. D. Severe allergic reaction. Answer, C. Brief asystole or bradycardia. This question addresses a common and expected transient side effect of adenosine due to its mechanism of action. The keyword potential side effect of rapid administration for adenosine is important. Adenosine works by temporarily blocking AV nodal conduction, and this effect can manifest as a brief period of asystole or profound bradycardia on the ECG, which is usually self-limiting and short-lived. For example, after a dose of adenosine, the patient's heart might briefly stop or slow down significantly before returning to a slower rhythm or normal sinus rhythm, which can be alarming but is an expected finding. It's important to warn patients about the sensation of brief asystole and prepare for it when giving adenosine. Question 26. What is the appropriate initial management for a patient presenting with an acute ischemic stroke who arrives within the therapeutic window and has no contraindications for fibrinolytic therapy? A. Administer aspirin immediately. B. Prepare for immediate surgical intervention. C. Administer intravenous recombinant tissue plasminogen activator, alteplase. D. Administer a calcium channel blocker. Answer, C. Administer intravenous recombinant tissue plasminogen activator, alteplase. This question tests your knowledge of the critical initial treatment for acute ischemic stroke. The keywords acute ischemic stroke, within the therapeutic window, and no contraindications for fibrinolytic therapy all point to the use of alteplase. Alteplase, TPA, is a fibrinolytic agent that dissolves blood clots, and it is the primary pharmacologic treatment for eligible patients to restore blood flow to the brain in ischemic stroke. For instance, if a patient is diagnosed with an ischemic stroke within 3 to 4, 5 hours of symptom onset, giving alteplase can significantly improve their chances of recovery by breaking up the clot. Always remember that alteplase is the gold standard for acute ischemic stroke when the patient meets all criteria and contraindications are absent. Question 27. What is the effect of atropine on the heart's electrical activity? A. Increases AV nodal conduction. B. Decreases SA node firing. C. Blocks beta-adrenergic receptors. D. Directly stimulates cardiac muscle. Answer: A. Increases AV nodal conduction. This question explores the specific action of atropine on the heart's electrical system, which is crucial for understanding its use in bradycardia. Atropine is an anticholinergic drug that blocks the action of acetylcholine at muscarinic receptors, particularly in the sinoatrial (SA) and atrioventricular (AV) nodes, leading to an increase in SA node firing and AV nodal conduction. For example, by removing the inhibitory effect of the vagus nerve, atropine allows the heart to speed up its electrical impulses through the nodes. Understanding that atropine enhances AV nodal conduction helps explain why it effectively treats symptomatic bradycardia. Question 28. A patient has achieved return of spontaneous circulation, ROSCI, but remains profoundly hypotensive despite fluid resuscitation. Which vasopressor is often considered for maintaining adequate perfusion in post-cardiac arrest care? A. Atropine. B. Epinephrine infusion. C. Adenosine. D. Sodium bicarbonate. Answer: B. Epinephrine infusion. This question tests your knowledge of common pharmacological interventions in the post-cardiac arrest phase, specifically for managing hypotension. The keywords ROSC and profoundly hypotensive despite fluid resuscitation indicate the need for a vasopressor to support blood pressure and organ perfusion. Epinephrine is frequently used as a continuous infusion in post-cardiac arrest care to maintain a systolic blood pressure greater than 90 mm of mercury or a mean arterial pressure greater than 65 mm of mercury, as it acts as both an alpha and beta agonist to increase vasoconstriction and cardiac output. For example, once the heart has restarted but the patient's blood pressure is dangerously low, a continuous drip of epinephrine helps stabilize their circulation. Always remember that vasopressors like epinephrine infusions are crucial for maintaining blood pressure after ROSC. Question 29. A patient in cardiac arrest with refractory ventricular fibrillation, VF, receives 300 mg of amiodarone. If VF persists and a second dose is needed, what is the recommended dose? A. 150 mg for bolus. B. 300 mg for bolus. C. 6 mg rapid for push. D. 1 mg for push. Answer: A. 150 mg for bolus. This question specifically addresses the second dose of amiodarone for persistent ventricular fibrillation in cardiac arrest. The keywords refractory ventricular fibrillation and second dose is needed indicate that the patient is still in a life-threatening rhythm after the initial interventions. According to AHA guidelines, if VF/private persists after the initial 300 mg amiodarone dose, a second dose of 150 mg for bolus can be administered. For instance, if the patient continues in VF after the first amiodarone dose, another, smaller bolus is given to further suppress the abnormal electrical activity. Remember that the second dose of amiodarone for refractory VF/private is 150 mg. Question 30. Which of the following drugs is a catecholamine primarily used as a vasopressor to increase systemic vascular resistance and blood pressure in hypotensive shock states? A. Dobutamine. B. dopamine, C. norepinephrine, D. epinephrine. Answer, C. norepinephrine. This question asks to identify a specific vasopressor drug based on its primary action. The key phrase, vasopressor, to increase systemic vascular resistance and blood pressure in hypotensive shock states, perfectly describes norepinephrine. Norepinephrine, also known as Levophed, is a potent alpha-adrenergic agonist that causes significant vasoconstriction, making it a powerful choice for profound hypotension and shock. For example, if a patient is in severe septic shock with very low blood pressure, a norepinephrine drip is often initiated to constrict blood vessels and raise their blood pressure. Always remember that norepinephrine is a go-to vasopressor for severe hypotension and shock due to its strong vasoconstrictive effects. Question 31. What is the recommended intravenous 4. dose of magnesium sulfate for a patient in cardiac arrest with torsades de pointes? A. 0.5 1 gram. B. 1 to 2 grams. C. 3 to 4 grams. D. 5 to 10 grams. Answer, B. 1 to 2 grams. This question specifically asks about the correct dose of magnesium sulfate for a particular life-threatening arrhythmia during cardiac arrest. The keywords cardiac arrest and torsades de pointes are crucial, as magnesium is the definitive treatment for this rhythm. The recommended dose of magnesium sulfate for torsades de pointes in cardiac arrest is 1 to 2 grams 4/IO, diluted in 10 milliliters of D5W or NS, given as a bolus. For example, if a patient's ECG shows the characteristic twisting rhythm of torsades, this specific dose of magnesium is given to try and stabilize the cardiac electrical activity. It's important to remember that 1 to 2 grams is the standard dose of magnesium for torsades de pointes during cardiac arrest. Question 32. For a patient in cardiac arrest, after establishing intravenous/intraosseous access, what is the recommended fluid bolus if 4 fluids are needed? A. 50 milliliters. B. 250 milliliters. C. 500 milliliters. D. Not routinely recommended during cardiac arrest. Answer, D. Not routinely recommended during cardiac arrest. This question addresses fluid administration during cardiac arrest. The keyword recommended fluid bolus in cardiac arrest is important. While 4 access is vital for drug administration, routine fluid boluses are generally not recommended during cardiac arrest unless there is evidence of hypovolemia as a reversible cause. Excessive fluids can lead to volume overload and worsen outcomes. For example, fluids would only be given if there's a strong suspicion the patient is severely dehydrated or bleeding significantly, not as a standard part of every cardiac arrest resuscitation. Avoid routine fluid boluses during cardiac arrest unless a specific, reversible cause of hypovolemia is identified. Question 33. Which of the following antiarrhythmic drugs can be used for stable wide complex tachycardia that is known to be ventricular tachycardia, VT, and does not respond to initial attempts at cardioversion? A. Verapamil. B. Amiodarone. C. Diltiazem. D. Adenosine. Answer, B. Amiodarone. This question describes a specific scenario for an antiarrhythmic drug in stable wide complex tachycardia, which is identified as VT. The keywords stable wide complex tachycardia, known to be ventricular tachycardia, VT, and does not respond to initial attempts at cardioversion point towards amiodarone. Amiodarone is a broad-spectrum antiarrhythmic that is effective for both supraventricular and ventricular arrhythmias, making it a strong choice for stable VT, especially if cardioversion fails or isn't immediately possible. For example, if a patient is conscious but has a fast, wide, complex rhythm, and the doctors decide against immediate electrical cardioversion or it wasn't successful, amiodarone would be administered to stabilize the rhythm. Remember that amiodarone is a key drug for stable VT that needs pharmacological management. Question 34. A patient is suspected of having a STEMI, ST elevation myocardial infarction, and is en route to a PCI-capable facility. What drug, besides aspirin, is typically administered early to prevent further thrombus formation? A. Warfarin. B. Clopidogrel, or similar P2Y12 inhibitor. C. Dabigatran. D. Rivaroxaban. Answer, B. Clopidogrel, or similar P2Y12 inhibitor. This question focuses on the dual antiplatelet therapy for STEMI patients. The keywords STEMI, PCI-capable facility, and prevent further thrombus formation indicate the need for powerful antiplatelet action. In addition to aspirin, a P2Y12 inhibitor like clopidogrel, prasugrel, or ticagrelor is typically administered early to patients with STEMI, particularly those undergoing percutaneous coronary intervention, PCI, to significantly reduce the risk of stent thrombosis and recurrent ischemic events. For example, when a patient has a heart attack and is on their way to the cardiac cath lab, giving them both aspirin and clopidogrel ensures maximal platelet inhibition to keep blood vessels open. Always remember that dual antiplatelet therapy, including a P2Y12 inhibitor, is crucial for STEMI management. Question 35. What is the primary role of vasopressin in the context of ACLS guidelines for cardiac arrest, as per current recommendations? A. It is the primary drug for all cardiac arrest rhythms. B. It is an alternative to epinephrine for non-shockable rhythms. C. It is not routinely recommended and has been removed from the adult cardiac arrest algorithm. D. It is used only for specific cases of torsades de pointes. Answer, C. It is not routinely recommended and has been removed from the adult cardiac arrest algorithm. This question addresses the current role of vasopressin in ACLS cardiac arrest management. The key phrases primary role of vasopressin and as per current recommendations are vital. According to the 2015 AHA guidelines and further confirmed in 2020 updates, vasopressin was removed from the adult cardiac arrest algorithm, meaning it is no longer routinely recommended for use. For instance, while it was previously considered an alternative to epinephrine, current evidence does not support its routine inclusion in cardiac arrest protocols. Always stay updated with the latest guidelines, as vasopressin is no longer a standard drug in the adult cardiac arrest algorithm.